My name is Adedayo Agio, and I'm going to be talking to us today about the very important topic, low vision and vision rehabilitation in glaucoma. I don't have any disclosures. This is the complex where we offer low vision services in Nigeria. These are some of my students. Now, this center is a regional referral center, and it's called the Lens Rehabilitation Foundation for the Blind and Severely Visually Impaired. It's located in Port Harcourt, Rivers State, and we have a comprehensive program to ensure all-round preparedness for independent, productive, and fruitful living for persons living with blindness in line with international best practices. We find that most of our trainees are blind, so we have to enter the community to ensure that the chiefs in the community are able to know what we are doing and be able to recommend it to their citizens. And we have some of them pictured here visiting to endorse the center. The same thing with the Nigerian Association of the Blind. We had the executive visiting us, and as a result of what we have been doing, we have been getting some awards. Now, what exactly have we been doing? We've been training in related areas to low vision. We've had over 200 eye care workers trained in Nigeria, from Gambia, Cameroon, and we've had inquiries from other countries made. We've had exhibitions, and we've had free outreaches looking for those at risk of blindness from glaucoma. We've given out free drugs, glasses, and given educational health talks. So to start on the leading causes of blindness around the world, we find that glaucoma, here pictured, is responsible for at least 10% of the causes of blindness around the world. And in the center here, we find that 2/3 of those who responded to the study that we carried out in our center, looking at the rehabilitation of those who are severely visually impaired and blind, we found that there was end-stage glaucoma in 2/3 of them, followed by congenital cataracts with poor vision post-operatively. We also found that 2% of those who were blind in the center were from couched eyes with severe, overwhelming inflammation. Other causes include trauma, congenital nystagmus with optic atrophy. So in this study, we took into consideration only those who are irreversibly blind. And looking at that, we found that glaucoma was mostly responsible. And this was also found in keeping with the Nigerian National Blindness Survey, where it was found that the glaucoma-specific blindness prevalence for those older than 40 years in Nigeria was one of the highest ever reported. This was also found in Nepal. So we found that this tragedy happens over and over again, especially in developing countries, due to poor screening and health-seeking habits of the populace, even if there is a positive family history. Looking at the epidemiology, we know that glaucoma, defined by visual field testing and intraocular pressure measurement, is the norm among those who take care of this patient. But low vision is generally defined by some through the limited scope of visual acuity, which is often not the primary complaint in glaucoma. We find that in glaucoma, vision is actually good until the very late stages. So somebody might not even know that he has glaucoma until the eye suddenly goes blind in maybe one of those times that the person notices it. So looking at the figures, 76 million have primary open angle from 2020 figures by a study by Allison and Patel, with an estimated 111.8 million to have it by the year 2040. So by extrapolation, 1.1 to 1.4 million Nigerians already have glaucoma, with an estimated population of 224 population in Nigeria of 2023. So this means 1 in 20 Nigerians have glaucoma, and 1 in 5 are blind from it. And we know that there's a lower report rate, so the figures could even be much higher. In Ghana, there is 45,000 people are blind from glaucoma, and we know their population is about 35 million from 2023 estimates. So what happens when eye care workers notice that their patients have gone blind? We know from one of the studies that we have carried out, when we interviewed about 150 eye care workers in Nigeria through social media and using Google Forms, we find that eye care workers have the responsibility of preventing blindness and maintaining good vision. And from that study, in addition, corroborating what I've said earlier, the most common cause among those who are working and taking care of blind people, of eye patients, is glaucoma, causing irreversible blindness. 83.3% of those who present with blindness. So when their patients go blind, that's about 87% of them, advise them rightly to go to a blind school. But only about a quarter of the respondents properly ensure that these students go. Most of these eye care workers would now begin to avoid these patients. So it's very important to ensure that eye care workers understand and know what to do when their patients lose vision. So it's also important to tell us again, for those of you who may not be very familiar, what glaucoma is. Now, in glaucoma, there are challenges with activities of daily living. There's also increased morbidity. There's consequent negative impacts on mental health, because over 90% of what we experience is from sight. So while disease progression targets medicine and surgery, there is irreversible vision-related disabilities that needs to be addressed through offering low vision services. So every ophthalmologist, every eye care worker requires information on how to recognize and respond to glaucoma patients that have low vision needs. So we'll go straight to talking about what low vision is. It's a condition where individuals experience visual impairment because of visual acuity that is 618 or worse, or tunnel vision, which is about 10 degrees from the point of fixation, and or distorted vision in the better seeing eye, even after correction with regular eyeglasses, contact lenses, medicine, or surgery. But who uses or potentially able to use vision for the planning and or execution of a task? So the purpose of low vision is to assess that residual vision and correlate it with the individual's social, educational, vocational, and other needs. And of course, to identify ways and means to enhance that residual visual function. So what are the steps in low vision assessment? We need to review the medical records, both systemic and ocular. If somebody has diabetes or hypertension, in addition, there could be some challenges which makes the management worse. Then you have to observe the individual, see how the person comes in, and other details which we're going to be talking about very briefly. Then interview the person and, of course, assess the visual functions. So you must have a complete ophthalmologic assessment. And of course, if you need to intervene medically or surgically, then you need to do that. So expanding more on the observation, you need to observe how the person performs visual tasks. For example, reading, writing, working with assistants. Does the person require that? How do they navigate steps? Then you have to check the quality of continuous reading. In addition, look at the speed of reading, look at the size of brain that the person is comfortable with, and check the errors in certain field locations. Also, you look at the speed of walking, how they swing their head, how they scan the room, do they miss objects or bump into items? These are the things that you need to look at. Then, of course, the case history. This is the most important part of the low vision examination. It helps us to establish exactly what the patient wants or needs. Usually it takes a longer time than the conventional history, and the patient should not feel rushed. You start with basic identifying information. You should develop a rapport and respond to the patient's emotions. Sometimes the patient starts crying and lamenting and regretting so many things. So you have to educate them about their problem and motivate them to adhere to prescribed treatment, because we know that this condition is not a stable condition. It also depends on whether they keep using their medication. Now, the contents of a good history is listed here. You must look at the basic identifying information: who accompanied the patient, what is the source of referral, how long ago it happened, then is it stable, do they have to constantly change their glasses? Then the patient's knowledge of the condition and the outcome, which eye do they prefer? Then the education, the employment, then how do you assess them socially? Then what adjustments have they made to the vision loss? What sort of thing do they even want or need? Then you look at what we call activity limitation. This is what a person cannot execute easily. That is very important to ask. What are the things that you want to do that you can no longer do as well? Then you also ask, what is the participation restriction? That is, a person's involvement in real life situation is impaired. You need to ask about that. So, because somebody's involvement in a real life situation, like maybe you want to play a game, you want to cook, you want to go out, maybe you want to visit someone, and you are not able to do that, that is what we call participation restriction. Then it's not until somebody goes completely blind that you say this person requires low vision rehabilitation. There are some signs that you need to take into cognizance even when the person is still seeing very well. For instance, they may say they need more light. In 57% of those who have glaucoma, they will complain that they need more light to see. Then 55% of them complain of blurry vision. 46% of them complain of glare, and some of them can no longer even drive when it is dark. Then 36% complain of a noticeable visual field loss. Even though they have 6'9", 6'12", 6'6" vision, they will say, I'm not seeing well. Then 30% of them complain of contrast sensitivity losses. We're going to expand more on all this. So if you notice any glaucoma patient complaining of all this, that means the person qualifies for a low vision assessment. And all this means that the person will begin to have problems with reading, with writing, with moving around. And most glaucoma patients who attending low vision rehabilitation are usually functionally using only one eye, but not legally blind. So you may be confused if you are not very familiar with all this. And I would like for you to know that if you are blind in one eye completely, it does not mean that you are 100% or 90%, it's 30% disability. So somebody may be using only one eye and is only 30% disabled. But at the same time, they need to be attended to. So in summary, you take a good history, you screen the patient for functional complaints, you look at the patient's quality of life and also their ability to perform activities of daily living. So now the evaluation itself. So what to generally evaluate in these patients is their best corrected near and distant vision after a very careful refraction. Then you should look at their visual field. Either you do formal testing or you employ the use of confrontation methods. You test for glare, you test for contrast sensitivity, you test for color, and you also do a filter test. Let's start with the visual acuity. Why test visual acuity? We need to do that because we want to establish a baseline for monitoring pathology. We use this to predict the magnification that the patient requires to achieve a particular goal. So what is recommended is to use high contrast charts and very good lighting. Then you encourage the patient to shift their gaze or move their head to find the optimum fixation point for the very best vision that they need. It is not recommended that you should use projection charts. Why? Because there is low contrast when you are using projection charts, and you have to use it in a dark room. When you do that, somebody who is already compromised in terms of needing more lighting will not perform as well. So you are supposed to use a Sloan chart. That means a chart that has CDH, KNOR, SV, and Z, and use a brightly lit room at 10 feet. Then of course, if the person is having problems for low vision in particular, you are required to use what we call the Early Treatment Diabetic Retinopathy Study Chart, the ETDRS chart. And for those who have poor vision, you start at 4 meters. Then if they cannot read it at 4 meters, you move to 2 meters. They cannot read at 2 meters, you move to 1. And then you move to 0.5 meters. And of course, if the person still cannot read all those distances, then you use what we call the Berkeley Rudimentary Vision Test chart. Here you have about 2 or 3 charts, the what we call the single tumbling E card pair, the grating acuity card pair, and the basic vision card pair. So no one should have what we call counting finger or hand movement vision. Everyone has a particular figure that is assigned to their vision. So if you are able to use all these, then you are able to assign a particular vision to anyone, no matter the level of the vision that they have. So these are the 7 WHO categories of visual impairment. And we have it up to 5, which is what we call blindness. So from this, we know that somebody has counting finger vision at 1 meter, that is 2 logma. And somebody has hand movement vision, is 3 logma. So everyone should have a particular visual acuity assigned to him or her. That's a presenting distance visual acuity. And with that, you're able to categorize to either mild, moderate, severe, and then blindness starts from category 3 to category 4 and category 5. And of course, we have the undetermined category or unspecified category for those who are extremely difficult to evaluate. Now, talking about near acuity, you need to carefully evaluate this because of reading difficulties that I mentioned that they usually have. So, what do you use for this? Use Bailey-Lovie near reading card. This test whole word read acuity is much better to actually tell them to read sentences than tell them to read letters, actually, because it's more useful in evaluating them using this reading aid and single letter acuity. Now, there are limitations of the visual acuity test. Clinical acuity does not give an accurate indication of what they go through on a day-to-day basis. That's the functional acuity. And of course, you have to do it under controlled environment and circumstances. It can be influenced by differences in contrast, sensitivity, glare, even the motivation of the patient. Even it could vary due to the test setting, the type of illumination that you have, even your relationship with that patient, and the kind of target that you are showing to the individual. Then you perform a refraction, looking for any possible refractive error. Always obtain the best possible refraction with the best possible visual acuity so that you can aim to give the lowest magnification. So you can start, if you don't know what to do in terms of the refraction, because there are no reflexes or there are very poor reflexes, with previous glasses. But retinoscopy is preferred to auto refraction due to media problems and eccentric viewing. So use trial frames, don't use phoropters, and then use large aperture lenses. Don't use the very small ones because those who have glaucoma have already field constriction. Then, of course, if you cannot see any initial reflex, try larger lens changes. And of course, if all fails, then you try wet refraction. That means you dilate with cycloplegics where necessary. Now we're moving on to visual fields. We know that visual field in glaucoma continues to constrict as the condition begins to progress until we have tunnel vision. So you evaluate the remaining field that is available for rehabilitation. The best is to use a Goldman perimeter using large stimuli. Of course, you can use a 10-2 field on the Humphrey automated visual field to check the remaining central field. But the visual field may not show all disability. The collaborative initial treatment, glaucoma treatment study found that more than 25% of newly diagnosed glaucoma patients report blurred vision, difficulty adapting between light and dark, trouble seeing in the dark, problems with bright light, and our visual field testing was only modestly correlated with their complaints. So these findings underscore the importance of screening glaucoma patients for visual disability instead of just checking the pressures and their fields. Now, another important visual function to evaluate is the contrast sensitivity. Identical acuities can yield substantially different visual capabilities. Somebody may have 6'9", another person has 6'9", but they behave differently because of problems with contrast sensitivity. This is important for resolving objects in our daily visual tasks, such as you want to recognize someone's face, you want to distinguish between pupils, you want to know where steps begin or where it ends. So we use the Pelleropsin sensitivity chart to do this. And these are one-size letters. All of the letters are the same size, but there's decreasing contrast, and the patient at least was able to see 40 m and test that person at 1 meter. Then we move on to color vision. What is recommended is the Farnsworth panel D15 test. If you look at this chart, this is a normal test. If you have someone who has problems with protanopia, looking at this axis, the findings must align with this green line. If somebody has problems with the Dutton axis, it must align in that axis. Somebody has problems with blue, it must align, whatever you are seeing must align on the Triton axis. That's how you know if someone has a problem. And we have people who have color vision loss in advanced glaucoma, so it needs to be tested, particularly in the red-green axis. So talking about glare, glare is a visual sensation caused by excessive and uncontrolled brightness in the field of view, limiting a person's ability to distinguish details and objects. We have two types, broadly. We have disability glare, we have discomfort glare. Disability glare is the reduction in visibility caused by intense light sources in the field of view, while discomfort glare is a sensation of annoyance or even pain induced by very bright sources. So how do you test? You shine light from a bright torch 15 degrees to the side, and then you test visual acuity before and after. Usually you find that it is reduced. So how do you manage glaucoma patients that have low vision? The goal, like every goal that we want to achieve in low vision, is to increase the patient's ability to maximize function with their remaining vision. Because this condition is an unstable one, you have to keep checking whether they are on their medications, whether they are using their medications, whether they are going for checkup for their pressures, and checking their fields from time to time. Then you have to ascertain, will the patient benefit from low vision aids? Will there be need for environmental modification? Will it be better to employ sensory substitution for this person? So it is distilled into 3 steps. First, find out the amount of vision the patient has. Secondly, find out the amount of vision needed to do the task that the patient wants to perform. Then 3, figure out the best magnification device that allows the person to do the task. Then you try out the device and modify if necessary, and you prescribe and schedule a follow-up visit. So there are 3 types of magnification in low vision. We have relative size magnification, relative distance magnification, and angular magnification. So in relative size, what you want to do is to increase the actual size of the object being viewed. That means you can use larger print material. relative distance, you want to reduce the distance between the object and the eye of the person that is having the issue. That means either you move closer to the object or you move the object closer to the eye. And then we also have angular magnification, where you employ the use of telescopes and magnifiers. So the methods to calculate magnification are so many. You don't need to do no more than one. We have the Levinson method, Kestenbaum's. You have ratio between best near to target VA, reading power needed to read 1M, Lovin's method, Bailey's method, using equivalent viewing distance or power. The most important thing is that you want to calculate and achieve magnification for the person. So having done that, for near, we are expected to prescribe handheld, stand, or high plus reading glasses or telescopic attachments to glasses, or you can even employ the use of electronic magnifiers, which is very excellent because they can vary magnification, you can change the contrast, you can use black and white reverse polarity, you can have illumination, or you can remove the illumination. Of course, you can also use computer screen magnification programs and screen readers for this patient. These are some of the devices that you can use for near vision. And for distance also, you can use telescopes, which could be handheld, it could be clip-on, or it could be binocular if there's vision in both eyes. And of course, you can use approach magnification also if all else fails. To enhance the field, you can teach the person, because they usually come with restricted field, to scan or to expand the field using various methods. Now, to scanning, you can teach them head swings, you can teach them eye sweeps, you can tell them to approach things slowly to be able to know exactly where objects are. This helps them to increase their awareness of the areas that need to be processed and develop a systematic plan for searching things. Then, of course, you can use field expanders, meaning that you can use magnifiers, reverse telescopes, or prisms to reduce the entire field into the central field or to the eccentric field where they can see, or transfer the peripheral field onto the central field. So this helps when the person is static. It's not for dynamic use. That means you can't use it while walking around. To control glare, because there is discomfort and it reduces visual task efficiency, you can manage by turning down lights, by adjusting the angle of incoming light, or by using absorptive lenses. To be able to manage disability glare, you can use polarizing lenses, anti-reflective coatings, and incandescent lighting. So adsorptive filters are important. You can fit it over the person's glasses, for example, yellow, brown. So you must have a whole range, amber. You must have a whole range. And this is used to reduce glare, photophobia, and to enhance contrast. You can also employ the use of photochromic lenses or use anti-reflective coatings. Now, everything is not just using telescopes or filters. You can also use non-optical devices. These alter the environment and help to make things easier to see by modifying their color and their shape, enhancing illumination, improving contrast, altering size and shape, even the position, and all this improves function. And of course, it's much cheaper than optical devices and is easily available. We have certain examples: magnifying mirrors, adjustable table lamps, writing guides, needle threaders, board line paper markers, talking watches or wall clocks, high contrast wristwatches or high contrast calculators or talking calculators, shades like caps, hats, side shields or visors, reading stands, and you can also use large print. In fact, the recommended large print size is size font 18 double line spacing, Arial font size 18 double line spacing. Of course, you can manipulate color and contrast between the wall and the ceiling furniture, coloring the wall, the root of the railings and the staircases differently, the doorknobs, the windows, kitchen decor. You can adjust bed sheets, curtains. You can use contrasting plates because of the food. It has to be different from the color of the food. The floor should not be rubbed so that it should not skid. And of course, talking about activities of daily living assistance for those who have glaucoma, sometimes they have eccentric fixation. So you train for preserved non-central vision. You can adjust the lighting in the room. It must be even, without shadow. It must be adequate for mobility and moving around, no glare or reflections. So putting the light in the middle is the best for those who have glaucoma. Of course, if there's a missing visual field, you can use a typoscope, signature guide, or place markers. You can use tactile aids using dots, plasticide marking pens. You can also use talking devices like I've mentioned earlier. And of course, you can employ orientation and mobility with a guide cane. There are so many things that you can use also using sensory substitution, like BP machines, blood pressure machines that read out, and guide canes that also vibrate, and reading material in Braille. Of course, you can also use software like job access with speech. This is a picture showing manual brailing going on. And we also have a Braille embosser at the center that is able to serve the needs of at least 4 states and the entire River State. And of course, the Braille alphabet is shown there, and someone trying to Braille here and reading the Braille. It's important to learn manual typing for those who require sensory substitution. And the computer, this is a computer class going on with JAWS software in use. And it will read, as you're typing, it will read out what you're typing. Also, teaching orientation and mobility, you see students, you have to teach them how to avoid obstacles so that they will not hurt themselves. We also teach them how to handle activities of daily living, learning how to cook without vision. We've had several competitions. Now, it's important to handle the mental health impairments that result from visual disability by networking and counseling them, offering social support, and of course the team concept. When there are lots of people that have the same problem, like a glaucoma club, it's important for combating increased rates of depression and anxiety. So rehabilitation is very, very important. It positively impacts self-reported daily tasks, including all the things I've mentioned: reading, mobility, visual information processing, and nearly 50% of those who are new to vision rehabilitation services report meaningful improvement after 3 to 6 months of going about it. So I'll just mention some of the barriers to rehabilitation from the physician. Many of them lack familiarity with the low vision guidelines, so it leads to low referral rates. And for the patient, some of them, because of the stigma of holding devices, they may not want to take up the use of devices. Cognitive factors are also there, because you have to have some level of ability to understand the use of these devices to be able to use it properly. Even transportation factors may deter patients from pursuing rehabilitation. So in summary, treatment outcomes are actually better when you offer low vision services. A significant improvement was found among those who had a low vision offered to them, in addition to giving them devices, compared with those who were offered low vision evaluation without the use of devices. And low vision rehabilitation is not limited to younger people. Even those who are older, we should not just relegate them to the background and say they don't need it. In actual fact, this particular gentleman went back to his village and is now a politician because of the information that he was able to get from rehabilitation. So in conclusion, the data for low vision in glaucoma patients is still developing, and there's a very large population of glaucoma patients, there is no doubt about it. Many of them have irreversible visual functional deficits, and patient disability can be targeted by understanding low vision examination and servicing, how to offer these services. It's also important to identify these patients in our practice, discuss strategies for improving their functionality, and refer them to the appropriate low vision service in a timely fashion. The ultimate goal is to enable patients reclaim their activities of daily living, and their independence, of course, and optimize quality of life. Your patient will be happier if these concerns can be addressed in your practice, or you are able to recognize and refer them appropriately. Thank you for your attention.